Good afternoon. I am María Jesús Pascau, member of the TransplantChild Executive Committee and Work Package 2. I'm also the Transition Coordinator for adolescent transplant patients at La Paz Hospital. My colleague, Paloma Martínez, is the reference nurse and case manager in the Transition Consultation for adolescent liver, heart and lung transplant patients. We both participated first in the initial literature review and then in writing the document that includes the recommendations agreed by the health centers of the TransplantChild network regarding transition programs for adolescent transplant patients. We want to present to you today the process of creating the consensus document that includes the recommendations agreed by a group of experts from the network regarding transition and transfer programs for adolescent transplant patients. This webinar has been prepared in collaboration with Work Package 7. Their task is the creation of clinical practice guidelines and clinical decision support tools. We thank them for their participation. There are some terms that are used repeatedly in the document, and we will also refer to them several times in this presentation. The first one is adolescents and young adults, commonly abbreviated as AYA, in articles about the transition process. The other important concepts are transition and transfer, which are very often confused. That's why at the beginning of the recommendation document the following clarification appears. Transition refers to the process of preparation and health education that begins between the ages of 12 and 14 in pediatric care and lasts for years. This process doesn't end when the adolescent moves to adult care, but continues for 1 or 2 more years to make sure the young person has adapted well to the new environment. Transfer is shorter. It's the process where the pediatric and adult teams exchange information and the young person stops being seen in pediatric care and begins follow-up in adult care. T&T refers to the whole process. What were the reasons for creating this recommendation guide? The first and main reason is that young people face serious difficulties during the transfer to adult care and often express unhappiness with these processes. Parents also report problems and dissatisfaction. On the other hand, when one conducts a literature search, it becomes clear that there is very little scientific evidence on the subject. Most articles talk about general aspects of the process or tools to use during it, but there are hardly any clinical trials. Additionally, there is huge variability in the implementation and development of T&T programs, as confirmed by the survey conducted across the different TransplantChild hospitals on this matter. The guide aims to provide a clear plan for successfully setting up a transition and transfer program for pediatric transplantations by helping young people adjust to adult healthcare and reducing risks, reducing unfair differences in health during this process, improving the quality of life and health of young transplant recipients and their families, and making the experience better for transplanted adolescents, their families, and the healthcare professionals involved.
Hello, this is Paloma now talking. So, to develop the document María Jesús just introduced on the recommendations on the implementation of a transition and transfer program clinic in pediatric transplantation, it was important to follow a structured methodology that ensures a clear and effective approach. So our first step was the definition of the objectives and scope of the document. So the end users of these consensus recommendations are the adolescents and young adults themselves and their families, as they have the right to know how they should be treated during the transition and transfer process and what support they can count on, and all the stakeholders, so all the health and social professionals involved in the transition and transfer process to adult clinics of AYAs who have been transplanted at pediatric age, so the pediatric services and adult services. So regarding the general objectives, these were to establish a set of consensus-based recommendations to improve the efficiency of the transition and transfer, and also the health status and adaptation of the transplanted persons during and after this process, and also to reduce the variability among healthcare teams regarding the management approach of pediatric organ recipients during the transition and transfer to adult clinics. And as to the specific objectives, these were to set up the basic desirable characteristics that a TNT clinic should have, to set up the minimum desirable composition of the transition and transfer teams, to establish the transition stages and milestones that the TNT clinic should support the AYAs in a TNT stage, to establish the readiness or adaptation criteria and procedures for transition to adult clinics, and to make recommendations on the implementation of TNT clinics and how to evaluate it. The second step was to carry out a qualitative review of the scientific literature. A search was performed in the databases Medline and Google Scholar. We also searched web pages of hospitals and medical centers related to children transplantation and asked European reference networks members for the current practices. The keywords used in the search strategy were transplantation and transition to adult care, and the types of articles included were protocols, programs, and any study that includes transplanted children, solid organ and or hematopoietic stem cell transplantation, aged 0-18 years, in the period of transition, including randomized controlled trials, controlled cohorts, and non-controlled cohorts. Case series and cross-sectional studies were excluded. So we found 395 publications. Abstracts of all recovered publications were read, so 257 were considered non-pertinent to the subject, 19 were merely informative, and 1 was a duplicate report. Therefore, 118 were selected for full review. These 118 were classified according to this type of publications. You see here in this table, and this table shows the sorting process of the articles found under classification by organ. The main topics covered were the following: structure of a transition clinic, key professionals of a transition clinic, skills needed for transition, medications and adherence, disease management, health management, lifestyle, mental health, quality of life, social issues, communication, system, patient, family, TNT stages, and educational methodology. So the third step of our methodology was to carry out a survey on transition programs to network members. So this survey was designed by La Paz Hospital Coordination Group during several meetings. This survey was launched in the EU survey. The data collection period was from the 30th of March 2021 until the 31st of May 2021. The target of the survey was any TransplantChild member and affiliated centers involved in the TNT process of transplanted children. The survey was sent to all representatives of TransplantChild centers, full and affiliated members, and to those that applied to be incorporated to the network. All these sum up a total of 42 centers. So what did we find? We received 54 answers from 35 centers in 19 countries. So 7 centers did not respond to the survey. 27 respondents were full members of the network, 7 from affiliated centers, and 21 were from new full or affiliated centers. In most of the cases, only one person filled the survey, so 23 centers. In 6 centers, there were 2 people, and in 5 centers, 3 people filled the survey, and 4 people answered in the case of 1 center. The main survey results were that a majority of the transition clinics, 57%, do not have a defined structure and functions. Preparation for transfer to adult consultations is one of the tasks that health professionals performed during follow-up appointments. The composition of the TNT teams is very variable. Some are formed by a large multidisciplinary number of members, up to 16, and in some cases only 1-2 persons are in charge of the clinic. The average number of hours dedicated to the transition clinic is between 2.5 and 5.5 hours per week. However, the center with the highest workload devotes between 120 and 150 hours per week to the TNT clinics, which is quite good. Less than 50% of the respondents report the existence of a written transition guideline or program for transplanted pediatric patients. 53% state that no written transition guideline or program exists in the hospital. So the age starting the transition process is very variable, from 10 years to 18 years old, and in most of the centers, 38, no clear ages are reported for the different phases in the process of the TNT. More than half of the respondents, 30, report difficulties in carrying out the transfer process to the adult team. Difficulties reported are quite varied: AYAs and families' dependency to the pediatric team, administrative barriers, disaggregated attendance in the adult care for complex clinical conditions, transfer to other locations, lack of institutional support, and lack of material and human resources. These results highlight the need for these recommendations and confirm, as the literature points out, that the implementation of TNT programs is far from being universal and well established. Step number 4 was the document drafting. Based on the lack of consistent scientific evidence on these requirements, it was considered that the best way to agree on recommendations for the development and implementation of TNT programs would be a clinical consensus. The coordinating center prepared a first document on the basic requirements for the development of a TNT program based on the results of the literature review and the survey conducted among the network's centers. The first step, once the first draft was completed, was to circulate the document to network members, physicians, nurses, other health professionals, and patients' representatives, for changes and comments on the document and to suggest recommendations. Changes and suggestions were included in the final draft of the document, and recommendations were ordered and structured for its use in the consensus process. The table of contents of the document drafting were the following: the background and specific objectives, the transition and transfer process, the characteristics and resources needed for a TNT program or clinic, and the principles for implementing a TNT clinic. The healthcare professionals involved in the development of this first draft were the following of these 9 different centers. The last step was the consensus through the Delphi strategy in 3 rounds. So, in order to reach a consensus on the recommendations for the development of a TNT program, the Delphi methodology was considered more appropriate due to the high number and the geographical dispersion of the panel members. The process was spread over 3 rounds, and the consensus panel members for the consensus process were recruited among volunteers within the network, including surgeons, physicians, nurses, psychologists, social workers, and patients' representatives. So in round 1, the panelists expressed their degree of agreement with the recommendations included in the questionnaire, and they could propose changes in the recommendations wording and suggest new ones. Then the final draft was carried out together with the modified recommendations questionnaire, and in the round 2 we obtained a feedback with a recommendation level equal or greater than 7 from 80% of the panelists. So it was considered a strong recommendation, and no text or changes were allowed in this round. The following health professionals were the panelists of the different centers who participated. And finally, here we have it, the document about the recommendations on implementation of transition and transfer program and clinic in pediatric transplantation. You can find it on the website of TransplantChild. And regarding the main statements of the document, the general objective of the TNT program was to work together with each adolescent and young person to maximize their strengths, to minimize the impact of their limitations, to successfully navigate their changing circumstances, and to improve their current life situation and prospects for the future. The characteristics of the TNT process were a whole person and family-centered approach to care. Transitional support should be flexible and evolve with the young person in keeping with not only chronologic markers but also developmental stages, and that the standard transition plan should be tailored to each patient. Other characteristics of the TNT process are monitoring the progress of the AYA and assessing their readiness for transfer using specific tools as the On-Track or Register to Go program. Early introduction, AYAs and parent or caregivers should be familiar with the transition process at the age of 12-14 years old, and that is very important to support professionals assigned for each AYA that coordinate the transition stages according to the AYA cognitive stages and developmental stage. Encompassing parents or caregivers, relatives, and other important people for the AYAs, for example, boyfriend or girlfriend, is very important. Peer support, group sessions with other AYAs in transition. For example, here in Madrid at La Paz, we performed the first transition journey with 20 AYAs, and it was very, very successful. And direct communication and coordination with the adult teams. And of course, I would like to remind you that you can subscribe to the TransplantChild newsletter if you're interested, or follow TransplantChild in the social media. Thank you very much for your attention.